I would say let's get started. It's beautiful weather outside. Most likely, if we're being finished, the sun will be going down already. But let's still be starting on time. Warm welcome to our symposium on Mondays of the Comprehensive Cancer Center. My name is Matthias Guckenberg. I will give you a short introduction to this series, and then I will hand over to the chair of the Brain Tumor Board and Professor Weller. So, quick introduction to our Comprehensive Cancer Center. You know, we try to have a comprehensive approach on patient treatment, education, research, and also in research and dissemination. Just a while ago, we transformed our education on the Mondays. You know that we had a weekly Monday lecture that was on various topics, and the issue was the participations was becoming somehow low, and it was a bit lacking of the focus. So we transformed these Monday lectures into monthly, call it small symposia, which are organized by the organ centers. Thereby we try to have a more comprehensive approach, a longer symposium which is covering the clinical aspects but also the research aspects. We have invited guest lectures here, and thereby we want to kind of bring the community in the respective fields together, and today this is going to be the neuro-oncology community. These are just the Comprehensive Cancer Center in some numbers, and most important that we have quite a number of organ centers, 17 in total, and they will be all hosting one of these symposia. This is the list of all organ centers you're being seen here, and the departments which are contributing. And this is the program for the symposia in 2025. So this is the second one. We have been starting last month with the breast cancer, and now the brain tumor or brain metastasis. With that, also many thanks to our supporters. You know that these kind of events are not possible without having some sponsorship and support. And so many thanks for staying with us and for supporting this series. And with that, I would like to hand over to Michael, please.
Thank you very much, Matthias. Warm welcome also from our side. Special welcome to Guido Reifenberger, who got up at 4:30 in the morning, roughly, to enjoy the beautiful weather in Zurich and talk about our common projects. We have two main topics. We have no break. So the first topic is melanoma, which is one of the strongest areas in cancer in our institution. And the second part is a bit more confusing. It's looking at what the WHO classification has generated in terms of trouble for clinical practice. And there we welcome Guido Reifenberger for the keynote lecture. Now we have 56 minutes left. We have 4 talks. So with 10 minutes, you're all in shape, I would say. So that leaves a lot of space for discussion. So we can move to pathology at 5. I've seen the 10 minutes break, Guido, between you and Regina. So we're going to close 10 minutes earlier, maybe. Patrick, you miscalculated that. Or I don't know. Or is there something specific between 5:30 and 5:40? Good. Good. The first part will be moderated by Emilie Levent.
Danke. So this is my pleasure to start this session on brain metastasis from melanoma. And I'm happy because that's also with partners that we have for the management of brain metastasis of melanoma, so really involved in the daily care and also in research. And they all have original manuscripts, so that's super. And we start with Dr. Voglis from neurosurgery to give an update.
Oh, sorry. So, hello, my name is Stefanos Voglis. I'm from the local neurosurgical department. And yeah, thank you for the invitation, Emily. And I was asked to talk a bit about available and novel surgical treatment options for melanoma brain metastasis, or maybe a bit more general about treatment options for brain metastasis, since all the tools we have in our gadget box are applicable to most of the different brain metastasis entities. I have nothing to disclose. the idea is to give you a bit of an overview about the classical approaches, meaning resection and biopsy, and how they evolved over time with different tools and technical advances, and then what local catheters we can apply, and then a bit about the newer tools, the laser interstitial thermal therapy and focused ultrasound, and which role they might play in the future. So classical indications for surgery for brain metastasis, as we all know, single lesions, when there's no histopathological diagnosis yet, so to confirm the diagnosis, and last but not least, in cases of symptomatic lesions, to improve functional outcome and functional status, and thereby facilitate further treatments and allowing patients to go into systemic therapies. Here you see a bit how the neurosurgical operation theater evolved over time. So from the pictures on the left side to the picture on the right side, a lot has changed, and a lot of different tools and technical gadgets are available nowadays. So from intraoperative advanced imaging to augmented reality to neuronavigation and so on and so forth. I will talk about this a bit later. But first I want to start about, from a surgical point of view, what is the difference between resecting a brain metastasis and even more in melanoma brain metastasis compared to primary brain tumors. So we tend to say that gliomas, from a surgical point of view, are way less demarcated, infiltrative, and therefore need a bit more experience to resect. And on the contrary, brain metastases tend to be easier to operate. And I mean, we know that this was already shown on a histological point of view, that although they do infiltrate a bit the brain parenchyma, this is way more limited compared to primary brain tumors. And this leads us a bit to our philosophy that even in more complicated or deep-seated brain metastases, in general, most of them are somehow surgically approachable, especially melanoma, since they tend to be even better demarcated from surrounding brain tissue. For example, here, one in the insula, one in the brain stem. So even those very rare cases can, in theory, be approached, or one in the left thalamus. So if you talk about classical surgical approaches to resect brain metastasis, we can distinguish the classical craniotomy, so opening of the skull and resecting the tumor, or the more minimally invasive approach to just place a burr hole and either resect a small superficial lesion via this single burr hole, or just take a needle biopsy to confirm the diagnosis. Speaking of biopsies, we have many different tools. For example, it started with a stereotactic head frame, which was invented many decades ago to do needle biopsies. Nowadays, we more and more use navigated frameless approaches, which are easier to apply and faster for the patient, but probably have a bit more of an error margin. And even for more complicated or smaller lesions, which are, for example, deep in the brainstem, one can even use a robotic-assisted biopsy system to really narrow down the error margin to millimeters in the end. Or what we use on a daily basis is the intraoperative ultrasound, not only to take biopsies, but also to guide our resection and to check whether there's big tumor remnants left, or there's any complication or bleeding. Now, if we talk about the resection, so removing a brain metastasis, we have many different tools. First and foremost, the skills, experience, and the knowledge, obviously, of the surgeon. And then all the different tools and gadgets we have nowadays. And I would say for brain metastasis, what we use in almost 100% of cases is neuronavigation and intraoperative ultrasound. And in selected cases, neuromonitoring, if the lesion is located in eloquent areas, to check on motor function, on map speech function, and so on and so forth. And in very selected cases in brain metastasis, also intraoperative MRI or awake surgery, but those are primarily used in primary brain tumors. So two examples. One is the intraoperative MRI, where you can see here previously operated and radiated brain metastasis, where we could check intraoperatively that there was some tumor left, and then proceed the operation to spare the patient an additional surgery, probably in the end, to achieve a better extent of resection. And also one very brief example that a resection does not necessarily mean a big skull opening or a big scar. So, for example, superficial lesions can even be approached with a single burr hole, which has probably the size of a thumb, and then can be checked with intraoperative ultrasound. It can be resected via this burr hole with an ultrasonic aspirator, and then checked again whether it was completely resected, and in the end leaves a scar of 2 to 3 centimeters. So it's not a big opening or big skin incision. So the safety of resections improved over time. So a couple of decades ago, the literature stated about 13% of complications and up to 9% of neurological deficits. Nowadays, in our cohort, we had over 600 patients and below 2% severe adverse events, below 1% mortality, and roughly 2% of neurological deficits. And just to mention it, the deep located lesions were not necessarily associated with more or more severe adverse events, which is somehow in line with our experience that they are better approachable compared to primary brain tumors. Intraventricular catheters, that's nothing new, but I think we used it in recent times more and more frequently, and we will hear later about the intrathecal immune checkpoint inhibitor trial. Though Meyer reservoir, it's nothing new. It was invented in the 1960s by I think from Pakistan, a surgeon, and initially for fungal therapy. And it's from our point of view, it's very easy to apply. It's a 20-minute surgery, and patient can even go home the same day or the next day, and probably they will be used more and more frequently in the future. Now, what is really new, or what has become new in the last years is, for example, laser interstitial thermal therapy. It's nowadays used in selected tumor indications, primarily in pediatric tumors, but also in epilepsy patients. And what we do is basically we place a catheter and then heat ablate the tip of the catheter with the tip of the catheter under MRI guidance, the targeted lesion. And the data on brain metastasis is very limited. It's just accumulation of retrospective studies. But for example, this study, they compared the craniotomy to the LIT, so the laser interstitial therapy for radionecrosis or recurrent brain metastasis after radiosurgery, and they saw no difference in progression-free survival comparing the two groups, but as one would expect, a better resolution of symptoms or deficits after the craniotomy compared to the LIT group. Or another study, they investigated how fast the patients could taper off the steroids in LIT after LIT therapy compared to medical management alone, and they indeed could see a faster steroid tapering after LIT compared to the medical management alone, but no survival differences again. So currently there's no really hard evidence to promote LIT, but it might be considered in very selected cases of progressive brain metastasis or for radionecrosis after radiosurgery. And I think one advantage is that in the case of radiosurgery, that radionecrosis, that one can also obtain tissue via this catheter to confirm or alter the diagnosis on a tissue level. Just very briefly, MRI-guided focused ultrasound is nowadays, like, we use it on a daily basis for like deep brain stimulation targets for Parkinson patients, for example. So as an alternative to the classic catheter-based deep brain stimulation, there's no incision needed. So basically, the ultrasound waves are concentrated in a single point, which one defines up front, and there are some geometrical constraints. So only lesions which are more centrally located in the brain are approachable by this. And the clinical data is almost not present. There are some studies which investigated the use of focused ultrasound to enhance the delivery or the uptake of, for example, here are HER2 antibodies in breast cancer brain metastasis, so to distract or make the blood-brain barrier more penetrable. But a recent review at least showed that the studies concerning the breakdown of blood-brain barrier by focused ultrasounds for cancer, so brain cancer patients in general, are on the rise, and probably there will be much more data about this in the future. So, but it's not yet in routine clinical use for sure. So I would conclude that the classical microsurgical resection of brain metastases with modern tools can be considered very safe, and almost every lesion is approachable. There are minimally invasive approaches which, to our point of view, reduce the surgical impact. So it's not like big scalp incisions nowadays. Ventricular catheters for intrathecal therapy are widely available and from a surgical point of view, easily applicable. And other methods like laser interstitial therapy might have a role for radionecrosis or recurrent brain metastases in the future, as well as focused ultrasound to enhance the drug delivery via the blood-brain barrier in the central nervous system for brain metastases. With this, I come to an end, and thank you for your attention.
Is there any question? Just one question. Did you see more indication for surgery for suspicion of radionecrosis versus real progression, or?
It's probably hard to, I mean, like for my limited time span, I'm in neurosurgical now, I think it increased, like that we operate more and more radionecrosis. But honestly, I have no data, like I have no experience for the last 10 or 15 years, but probably it will increase in the future, right? Mm-hmm. So we see it more often, for example, in the melanoma board that we discussed. Could it be radionecrosis? Could it be tumor remnant? And in the end, if it's relevant for the next steps or next systemic therapies, then we usually take the tissue out and see what it is.
Okay. Patrick?
Yeah. I was just wondering, I think it's well accepted that melanoma tends to bleed much more frequently in the brain than other metastases. So I was wondering if this makes a difference in your surgical approach, and more specifically, since you mentioned LIT and ultrasound, where the tissue gets heated. So is there an even higher risk that it comes to bleeding during the procedure?
So during LIT or focused ultrasound, we never used, it's not widely used for brain metastasis, just in the really experimental setting. For LIT, there's no data on whether they tend to bleed easier from the classical surgical approach to operate on bleeding from melanoma brain metastasis tends to be even easier because you have the bleeding cavity. And the blood usually comes out quite fast, and then you have more space to really delineate the tumor tissue from the healthy brain tissue.
We're having particular difficulties if there is a cystic brain mets, and there are some reports about cyst aspiration and then followed by a radiotherapy approach. What is your opinion on a staged or kind of combined modalities local strategy?
I mean, I know there are some reports about that. So you mean to first aspirate the cyst and then go for the radiosurgery? I mean, probably if it makes the radiosurgery more easier or more. From our point of view, it's not difficult to aspirate the cyst. So one could even do it with a tiny burr hole and a catheter and frame-based or whatever, like a biopsy. So it's from a surgical point of view, not difficult to do. And if it makes sense to plan the radiosurgery better or deliver more doses on the tumor itself.
I mean, it's an interesting approach. It immediately reduces the pressure and kind of makes our radiotherapy volumes much smaller.
Yeah.
Okay, so thank you very much, Stefanos. We'll move to the second presentation by Dr. Palembos from the Radiation Therapy Department. So,
Dear colleagues, thank you for your kind invitation. My greetings from the Department of Radiation Oncology. It was a difficult task to explain everything about melanoma metastasis, and on the other hand, I thought it is a good opportunity to find a more interdisciplinary topic. Therefore, I'll focus on the irradiation of resection cavities, also because this is based on a recent analysis that we did together with the departments of dermatology and neurosurgery. And here you listen a bit about the background, what we did in this analysis, the results, and then after the outcomes, I will show you the current practice and the new guidelines that will be published in a few days. So first of all, the paper I can only recommend is a recent review. It was published in Nature Reviews a few days ago, actually, and tries to summarize this difficult task of putting every metastasis radiosurgical treatment together, which you will see is everything else that easy, because as I will show you in one of the next slides, the algorithms become more and more complicated with the advances of systemic and topic treatments. So to go back to brain metastasis of melanomas, we know brain metastases affect up to 20% of all the cancer patients, but in melanoma it's more frequent, and at least anecdotally, we know they're more resistant to radiation. To be honest, there are no clear radiobiological data about that, but we know, especially from the time before effective systemic therapies, patients had a worse prognosis despite radiotherapy. As you have listened before, in case of larger or symptomatic lesions, surgical resection is a treatment of choice, and there comes the situation where we have an interdisciplinary board where we sit everybody together and decide mostly in favor of radiotherapy, and I will show you why. So the incidence is very high in melanoma, and before radiosurgical treatments and before immunotherapy, the median survival was below 6 months. Please imagine that, keep in mind, and compare with the data that I will show you later. We tried here to focus on the importance of integrating every part of modern treatment, a modern ablative local treatment with the most modern systemic treatment, and so that both of them are useful. Here you see overview of the formerly review that I was referring to. Asymptomatic lesions of melanoma here should be treated frontline with systemic therapy. Why we do not select? I think it is another discussion. There are always patients who will benefit from an upfront local treatment, that I will show you how we solve this in the Swiss guidelines at the end. But let's concentrate on the symptomatic lesions, where here is upfront radiosurgery or fractionated radiosurgery recommended. Here again, where is the surgery is also missing. So you see, if you try to summarize such a complex topic in an algorithm, it's always difficult. So our objective was to evaluate the outcomes. It is the first time that one group tried to include only patients receiving modern treatments, no patients with best supportive care, no patients with chemotherapy like in the old times, and only patients with modern stereotactic radiotherapy and no whole brain irradiation. Most of the cohorts that you see elsewhere in the literature always mix these situations. And maybe this 79 resection cavities doesn't hear like a very large number, but if you imagine that we have a very homogeneous cohort, this is the strength of this work. This has been never described before in this homogeneity. And with a long follow-up for such patients, you see typical situation. The most common fractionation was 6 times 5 grays, so 6 fractions, because there were also very large lesions included. And this is a typical case. So when we get the patient a few weeks after treatment, the optimal time point is around 3 to 4 weeks after surgery. We mostly have such a situation. This is a bit larger resection cavity. We delineate the cavity in a high resolution MRI. And here you see the plan. The blue isodose here is something about 10% of the dose. So this is a dose which is not dangerous, not toxic for the brain tissue, for the healthy brain tissue. And that's the secret of stereotactic treatments. You see, if we focus on the 95% isodose, how conform it's around the resection cavity, this high dose radiation goes only there where it should do. And you see this excellent overall survival, something which was non-imaginable before the advent of new systemic treatments, of course, and before the advent of stereotactic radiotherapy, 2.3 years. And compare now with my initial slide with the 4 months. And as you see here, this is the added value of stereotactic treatment. The 47 or 42% intracranial control, this is what we get with modern systemic treatment in a real-life population. In the studies, a bit more. So the double immune checkpoint inhibition, which is the standard, and which received over 80% of the patients in this cohort, has an intracranial control reported about 50 up to 55%. But you see in real-life population, it's even a bit less. And the additional gain here in the local control is due to surgery and radiosurgery. So you get a very decent control of the locally treated metastasis of about 80%. And this difference is this gain in progression. If this translates also in an overall survival benefit, it is still a matter of research, and I will show you at the end how we approach this topic in the US set. You see the toxicity is very low. We had only 12 to 14% toxicity, mostly asymptomatic radiation necrosis, where what it makes difficult is to differentiate this necrosis to the few patients that get a local recurrence, and therefore we need another specialty in our interdisciplinary work, the nuclear medicine. Without their help, it would be sometimes impossible to tell if this is a radiation necrosis or not. And for this purpose, we use always tyrosine amino acid PET MRI in the US set. So to conclude, we have very high local control achievable of about 80% with this combination. There are challenges. Despite the excellent control, most of them is the intracranial control, which is far from satisfying, yet with about 40 to 50%. And this supports the clinical adoption of surgical and radiosurgical treatments, because you see this is a low toxicity treatment with modern approaches. Post-operative radiosurgery can be combined safely with modern treatments, with both immunotherapy and, of course, targeted tyrosine kinase inhibition. And we need a close MRI surveillance due to the frequent intracranial out-of-field recurrence. Prospective trials will also evaluate the potential benefit to overall survival, like the ETOP strike, which you will hear later. There are also emerging trends in modern radiosurgery. We have the possibility for frameless immobilization. 20 years ago, every patient received screws on the head, in the head. So nowadays, we don't need something like that. We have improved targeting. We have even AI-based algorithms to help with segmentation of tumor and organs at risk. And we have some shifting paradigms. So there are even studies that evaluate neoadjuvant preoperative radiosurgery. Why? One of the rationales behind that is that you have an much better immunological response if you irradiate before. If you have the tumor, you irradiate the tumor, and you have a production of neoantigens, and this can facilitate even the effect of immunotherapy compared to only a post-operative radiation where you don't have enough tumor. More neoepitopes, there are a lot of immunological reasons to go for neoadjuvant treatments. Then we can combine with even more novel systemic therapies, like, for example, intrathecal treatment in challenging situations where the patient has metastasis, so solid metastasis and meningiosis, for example. And there is even studies that show that the sequential approach of radiosurgery and followed by immunotherapy could lead to improved immunological responses and outcomes. There are a lot of challenges also. So it's always difficult to differentiate between tumor recurrence and necrosis. And there are novel biomarkers where you don't even need to take blood from the patient for this purpose, but radiomics could help for this. And there's a lot of research ongoing for this differentiation, which goes beyond, of course, the very good work done by the Department of Nuclear Medicine via amino acid PET. There is also research about dose and fractionation. There are current trials which compare these two approaches. Of course, you can irradiate everything in only single fraction, but larger lesions in single fraction is more toxic. And they are traditionally centers that apply only single fraction go to a lower dose for this approach. Therefore, there are good randomized trials about that, and also trials investigating potential synergy between the systemic treatment and the radiotherapy. And last but not least, re-irradiation. As you see, some of the patients will need re-irradiation, both or mainly in proximity to other irradiated lesions, but sometimes around 10 to 20% even in-field recurrences. And there is a large prospective cohort of EURTC which will evaluate in-field and near-field re-irradiation in the brain. You will hear more about this excellent trial later, but this is what we prefer to do in USA, to randomize patients which are asymptomatic, both of patients with intact metastasis and resection cavities, oligometastatic, to receive upfront radiosurgery or salvage radiosurgery. And we know it is safe, it is feasible, it leads to a good local control, but this study will hopefully show if there is a survival benefit. And I'm proud also to present you the new Swiss melanoma guidelines, which will be published in a few days. So if we have more than 10 asymptomatic metastases, we go always for upfront systemic treatment. It doesn't make any sense to try to irradiate 30, 40 asymptomatic small metastases. If you have a brain oligometastatic disease, we recommend always at least to discuss radiosurgery, because as we have seen, there is excellent local control, and some patients may even have long-term benefits. If you have now patients not qualifying for the standard systemic of care, which you will hear, but it's double immune checkpoint inhibition or TKI, and there are not few patients with the aging population. You have a lot of patients which are not, which are frail to receive double immune checkpoint inhibitions. These patients should always receive radiosurgery, because the local control of this metastasis is even lower than this 40%. And here in green, our main topic of this talk, adjuvant radiosurgery for resection cavities is always recommended also for smaller cavities, at least outside of clinical trials. Last but not least, important, whole brain radiotherapy is out and should not be performed. It is associated with neurocognitive deterioration. So what we do in OSET, 1 to 10 metastases asymptomatic, always screen for STRIKE trial. Also for resection cavities are also allowed to be included. The best treatment for every patient is a clinical trial, and that is an additional benefit of referring patients to large centers like the USET. Outside trials, 1 to 10 asymptomatic, we go for ipi-nivo. If the patients are not eligible for ipi-nivo or TKI, then always radiosurgery. Otherwise, in oligometastatic, consider radiosurgery based on different factors like tumor localization, fitness, etc. And the not so uncommon situation like you have seen, 40 to 60% of progression under systemic treatment, always consider radiosurgery for this patient. In symptomatic metastasis, like in our study, in our previous analysis, always consider surgical resection for 1 to 2 symptomatic lesions. and always radiotherapy to the resection cavity for oligometastatic situations. Thank you very much.
Thank you very much for the nice presentation. So, question, Egil.
Thank you so much, Panos. As usual, great presentation. My question is there an impact of survival after SBRT for spinal cord metastasis or only for the brain metastases?
This is something where we have even less data. You mean intraspinal metastasis? We don't know. This such rare situation. The largest cohorts there, Matthias wants to say some. The largest cohorts are only a few patients with intraspinal.
I would say, I mean, the most frequent indication is not overall survival, except these patients are symptomatic. So a patient having either metastatic spinal cord compression, having neurological symptoms. So it's a palliative procedure. Then you have the risk of fracture if you have a bone invasion. So it's mostly local. And I would not ask the question whether this local intervention will in the end prolong survival for the patient. There I would more focus on quality of life.
Not to be confused with vertebral metastasis and bone.
Intraspinal, you mean? Very rare.
The largest series I know something 30, 40 patients.
Quick question, quick answer. You have something else to? Oh, okay.
Yeah, I would also agree anyway that if you irradiate spinal cord metastasis, your goal is quality of life, preservation of function, and even we would recommend it even if it didn't prolong survival, right? Can you update us on the state of pre-surgical SRS in Zurich?
Not really, because of course we like to make such treatments within clinical trials. And there was no agreement, found no possibility to open this trial, although in other Swiss and German centers it's ongoing now, but it's still recruiting. So we don't have a standard neoadjuvant approach in Zurich.
What is your opinion on this?
So I think it's very interesting from immunological point of view. And we have seen in many other situations, especially in curative melanoma, that it's always better to apply immunotherapy before removing the tumor the one way or another. So if you have these patients with 1, 2 larger metastases, irradiate, and you have your neoantigens, you have the possibility to have more epitopes for your T cells, an intact local immune microenvironment, then you remove it, and then you have also a much better ratio of T cells to left tumor cells for the immune effect to apply.
Thank you very much for the nice presentation. And now we'll hear what Dr. Hamlit from dermatology has to say to support systemic treatment.
Thank you so much. So before I start, Panos already mentioned the relevance of brain metastasis in patients with melanoma. However, to everyone who hasn't done this yet, I really recommend reading this paper about why do patients with cancer die. Patients ask this, and sometimes it's an interesting question to think about. So in melanoma, we use more and more adjuvant therapy. And the question is, does it also protect the patients from developing brain metastasis? We give adjuvant therapy as early as in stage 2B to 2C, which is without sentinel lymph node positive. And you can see in a cohort of patients who received nivolumab or pembrolizumab, 2 to 4% will develop brain metastasis as their first distant metastatic site. In stage 3, also with adjuvant immunotherapy, you can see it's 6 to 8% who will develop brain metastasis as their first metastatic site. So it's a lot. And we do see patients going from adjuvant to brain metastatic. What about neoadjuvant therapy? Again, a pretty recent study where patients received either neoadjuvant therapy followed by surgery and adjuvant therapy, or surgery followed by adjuvant therapy. You can see it in blue line, patients who received neoadjuvant therapy, and red line, patients who received adjuvant therapy, and there's a remarkable difference in distant metastasis-free survival. However, if we look at brain metastasis as first metastatic site, 4% with neoadjuvant, 3% with adjuvant. So it doesn't really change the risk of developing brain metastases. So what are recommendations for patients with melanoma brain metastases? Those are the ESMO guidelines recently published. And you can see that recommendations are separated into patients with leptomeningeal disease, symptomatic brain metastasis requiring steroids but less than 10 milligrams, and asymptomatic. I will not go into much detail of standard of care, but just to summarize, in patients who have BRAF mutation and have symptomatic brain metastasis, we would always start with kinase inhibitors, BRAF and MEK inhibitors, to reduce the tumor burden, reduce the symptoms, and then see when we can change to immunotherapy. For patients with asymptomatic brain metastasis, we always start with immunotherapy first because we know the long-term outcomes are much better. However, what's important that almost all of these indications have clinical trial as one of the first recommendations. So what can we recommend in terms of clinical trials? First, overview of what we know from prospective clinical trials. In yellow is the targeted therapy trial COMBI-MB, where patients received dabrafenib trametinib for asymptomatic or symptomatic brain metastasis. In blue, studies with immunotherapy, both with ipilimumab, nivolumab, or in nivolumab monotherapy in the ABC trial, and Tricotel has both targeted therapy and immunotherapy. Looking at the response, we see it ranges from 46 to 58. So I would say pretty similar. In progression-free survival, also 5 to 6 months, also pretty similar. For symptomatic patients, it looks a bit different. For immunotherapy backbone studies, we see that the response rate are lower, so from 56 to 40 and 35. However, with targeted therapy only, it remains very high. Again, this leads to the recommendation that we have in patients with symptomatic brain metastasis, start with targeted therapy, and all others start with immunotherapy. Progression-free survival is still very low and very short, 1.2 to 5 months. Now to the new treatments that are available. We use bevacizumab every now and then, and we discuss this at the tumor board for patients who have radionecrosis and metastatic melanoma with edema-triggered symptoms. And this clinical trial looked at bevacizumab and pembrolizumab, anti-PD-1 therapy. It's known that VEGF is important in vasculature of the tumor. It also increases lymphocyte adhesion to vessel walls and could lead to elimination of immune cells from the tumor. There are a few studies ongoing with lenvatinib, another multi-kinase inhibitor. But in this trial, patients with untreated brain metastasis, either untreated systemically or for brain metastases but have progressed, were enrolled. They were allowed to be as big as 2 centimeters and were not allowed to require immediate topical therapy. Patients with leptomeningeal disease were excluded. And the primary endpoint was the response rate of brain metastases. Patients received 4 infusions of pembrolizumab and bevacizumab, 7.5 milligrams per kilogram every 3 weeks, and then continued to pembrolizumab. So the schedule similar to ipilimumab, nivolumab. And the trial enrolled 37 patients in total. It was prematurely closed due to COVID and slowing down of recruitment as ipilimumab, nivolumab was made standard of care for this cohort. Now, for baseline characteristics, you can see that 40% of the patients had more than 5 metastases. 95% had brain metastasis as new metastatic site. The sum of intracranial target lesion, 15 millimeters, and 80% had no prior systemic therapy, so almost exclusively treatment-naive population, and 50% had prior local therapy for brain metastases. Here in the blue, you can see the response of intracranial metastases, and in red, you see the response of extracranial. On the left side, the patients who have progressed, on the right side, the patients who have responded. And what I've noticed that in some cases, there's discrepancy. So, for example, these two patients have a progression of intracranial, however, response of extracranial. However, on the other side, there are quite a few patients who have response of intracranial metastasis, but lack of response or lesser response of extracranial metastasis. So interesting to observe and potentially an idea for a combination. However, despite this discrepancy, brain metastasis response rate and extracranial response rate was pretty similar, 54 and 56. And we see that toxicity was not very remarkable, mostly headaches or immune-related adverse events from pembrolizumab. Now, looking at the progression-free survival, 2.2 years, so not bad. 1 year progression-free survival, 52, and overall survival, 4.3 years. So also not too bad for patients with melanoma brain metastases. As mentioned, there's a trial with lenvatinib and pembrolizumab ongoing. And another trial that looks at combinations of anti-PD-1 with anti-TIGIT alone, anti-CTLA-4, and anti-CTLA-4 pembrolizumab and lenvatinib. It states that they don't enroll patients with active brain metastases. However, brain metastases up to 1 centimeter are allowed. And there's another trial, Umbrella 2B, that exclusively looks at patients with either PD-1 naive or pretreated brain metastases, and look again at the triple combination of PD-1, CTLA-4, and lenvatinib. Those studies have finished recruitment, and we expect results by the end of this year. Now, as mentioned by Panos before, the standard of care for patients with brain metastasis is ipilimumab, nivolumab, and this is mostly based on this trial. It's called ABC, and a few weeks ago we had the 7-year follow-up for this trial. To briefly summarize, patients with asymptomatic brain metastasis were randomized either to receive ipilimumab, nivolumab, nivolumab monotherapy, or patients with symptomatic or pretreated brain metastasis received nivolumab. On the left lower side, you see the best progression-free survival patients with asymptomatic metastasis who received the combination of ipi-nivo, and nivolumab alone acts similar to patients with symptomatic or asymptomatic brain metastasis. So based on that, this is now indeed standard of care for patients with BRAF wild-type tumors or with those with asymptomatic brain metastasis. And based on this study, a few other trials have been initiated. So ABCX is a clinical trial in phase 2. They plan to enroll 218 patients and randomize them to receive either ipi-nivo alone or SRS within 7 days of treatment start. They allow metastasis up to 3 centimeters, no leptomeningeal disease, and no prior therapy is allowed for patients after they develop brain metastases. Another study with low-dose ipilimumab with pembrolizumab, so not the ipi-nivo, what we're used to see. Again, in patients with brain metastasis, no LMD allowed, prior anti-PD-1 is allowed. And what is interesting here is the low dose of ipilimumab is not defined in the clinical trials website, and it's ipi biosimilar and not the original ipilimumab. Now, sequential combination of immunotherapy and targeted therapy. To remind you about the clinical trial, patients were randomized to either start with encorafenib binimetinib and switch to ipi-nivo under progression, to start with ipi-nivo and change to encobini at progression, or do the sandwich, run in with 8 weeks of kinase inhibitors, switch to ipi-nivo without progression, and then at progression change to encobini. This trial was designed for patients without brain metastases, and as we can see that patients who start with immunotherapy and not targeted therapy have better outcomes in terms of progression-free survival and overall survival. Also, those who have not progressed under encobini have better outcomes. So the plan is, or the goal, to start with immunotherapy or stabilize patients and don't let them progress under kinase inhibitors. So what about the development of brain metastasis? Same question that we asked at the adjuvant study. Looking at all patients who have ever developed progression, we see that the highest number of patients is in those who started with kinase inhibitors and then switched to ipilimumab, nivolumab at progression. Progression 1 is after the first systemic therapy. Again, most of relapses on BRAF and MEK inhibitor and less in immunotherapy backbone. And for second progression is the same. Patients who have then progressed on kinase inhibitors develop more brain metastases. So we can say that in the brain, again and again, immunotherapy seems to work better, and kinase inhibitors are useful for stabilizing the disease, but not to achieve progression. Same for brain metastasis-free survival. The two upper lines are from immunotherapy backbone, and after development of brain metastasis, again, better in patients who start with immunotherapy or do the sandwich. There's a trial that looks at sandwich approach in brain, 8 weeks of encorafenib imatinib, followed by cemiplimab, fianlimab, so a combination from Regeneron. Very interesting approach. This study is running in Spain only. And another study looking at the triple combination, encorafenib and imatinib, so the kinase inhibitors plus nivolumab versus ipilimumab, nivolumab. We know that Tricotel study that also had immunotherapy and targeted therapy was not as successful as we expected, but what's interesting here is that patients with leptomeningeal disease are allowed. So maybe we'll have a new signal for the triple combination in this patient cohort. Now, anti-PD-1 and LAG-3, the most recently approved systemic therapy for metastatic melanoma. Again, looking at the progression, at the overall survival hazard ratio 0.8 per protocol. The primary endpoint was not met. This is the secondary endpoint. However, we still use it quite often. Same question, is it protective of brain metastasis? In the patients who received the combination, 17 or 5% have developed new brain metastasis on study. Patients who received nivolumab monotherapy, 10%. So it seems like LAG-3 may be also protective against brain metastasis. And looking at the time, it's also a bit later with the combination compared to nivolumab monotherapy. After 7 months with monotherapy, 11 months after the combination. There is a clinical trial looking at this cohort only. Patients up to 3 centimeters, no leptomeningeal disease, and the primary aim is intracranial response rate. Another study looking at the triple, so ipilimumab, nivolumab, and relatlimab in patients with asymptomatic and symptomatic brain metastasis. They're looking at the intracerebral benefit, so stable disease or better during the 6 months. What Panos mentioned a bit, ipilimumab with ipilimumab or relatlimab in surgically resectable brain metastasis. Here, instead of radiotherapy, patients receive 1 infusion of ipi-nivo or rela-nivo, and they will undergo a resection of brain metastasis 7 to 10 days later. The primary aim is feasibility, but we'll see maybe it will result in a neoadjuvant approach. And what I think is very exciting is we talk about immunotherapy a lot, but we have our own immune system, and there's a phase 1 to 2 clinical trial looking at natural killer cells from universal donor as a treatment approach for patients with metastatic melanoma to the brain. So to conclude, we see that the majority of the trials are looking at the immunotherapy, mostly because the target therapy approaches are successful only for a limited time. Combinations is another approach, but maybe, again, for patients who don't have symptomatic disease. Neoadjuvant approach, very interesting with radiotherapy, but also with immunotherapy. And a reminder, the clinical trials may be really the best approach for patients with melanoma and brain metastasis. Thank you so much.
Thank you very much for the nice presentation.
Maybe excellent talk, Egle. One short question. In which cases you would go for Opdualag as some Nivorella? Only in patients that do not tolerate the Ipi/Nivo?
So with brain metastases, so far we have only the data for ipilimumab nivolumab. So we would always go for that combination if the patient is fit and young enough. But in elderly patients, we would go for relatlimab nivolumab. There's a study that compared the combination, the differences in terms of PFS and OS for extra cerebral metastases are not that striking, but still we go with Ipi/Nivo almost always.
Thanks for the presentation. When looking at the ABC data, I mean, there's the patients which are responding and they have a long-term benefit, but there's quite a proportion, 50% of the patients which effectively are going down on the curve within very few months. I mean, how can we better identify these patients? Because that is my concern. If we go for a Nivo-Ipi approach only, patients will become symptomatic. If we know they're being symptomatic, we will have much less treatment options.
Honestly, for asymptomatic patients, we know that the more of metastasis, the worse the outcome. But otherwise, I'm not aware of any other ways to identify poor prognostic factors in the brain only. Of course, we have LDH, we have tumor burden outside, but for brain only, I think it's a gut feeling for now.
I have just a quick question. How comfortable do you feel with the triple combination, and which would be the potential indication now?
For treatment combination, so only for brain, Ipi/Nivo always.
Yeah, but a triple combination.
Oh, the triple.
Yeah.
Somehow relatlimab seems to be not too aggressive when it comes to toxicity, so it may be a good idea. We have the BMS data from 048, where it was anti-PD-1, CTLA-4, and or LAG-3 for patients without brain metastasis. We saw a lot of colitis, but the study data doesn't show that, so I wouldn't do it outside the clinical trial.
Thank you. And you? Okay. So we switch, and I will simply present some preliminary results from the ITIO study and the STRIKE study. So this kind of slide. We start with ITIO. So it's about intrathecal administration of Ipi/Nivo in combination with systemic Ipi/Nivo. So in patients with a new diagnosis of leptomeningeal metastasis and patients who have non-small cell lung cancer or melanoma. And I see melanoma is missing on the slide, sorry. Great. So this is a study design. So for the phase 1, so we start with 1 dose of Ipi/Nivo alone, and then from the second intrathecal injection, we add the systemic treatment, and we add what was at the time of designing the studies, the standard systemic treatment that we simply add on top of the intrathecal treatment. So yeah, intrathecal, and so in green you have the Ipi/Nivo and Nivo alone, and we add predefined 3 dose levels. So the dose of intrathecal nivolumab was based on the results of the study done at MD Anderson by Isabella Glitza, and it was shown it's safe. So we used this dose, and on this we added some ipilimumab, so at 5, 10, and 20 milligrams on top. So that was the eligibility criteria. So adult patient, of course, non-small cell lung cancer, melanoma, newly diagnosed, confirmed, or probable LM. It means that we need to have CSF positive cytology or characteristics, images, and clinical data. And steroid dose should be maximum 4 milligrams per hour for at least 7 days. we could have some coexisting asymptomatic brain metastases, and for the radiotherapy, we could treat locally, but of course, no whole brain, but we have heard it's not really an indication for this patient. So this is the status. So we have enrolled 19 patients between January 23 and August 24, so in 20 months. So it's almost one patient per month. So that was target initially. So we can see that Zurich I have not put, but if it's 111, it means that it was 16 for Zurich. So this is mainly a Zurich study. And so, yeah, this was enrollment, and in green, what we performed. So now the study is close to enrollment. Here I showed a case. So we have run the study. So we have defined the recommended phase 2 dose. So at 50 milligram Nivo plus 20 milligram EP. And this is a patient, non-small cell lung cancer, so 70-year-old. And so you see we had a CSF baseline that was positive, so with tumor cells, and then progressively it became negative. Then we had two, again, positive CSF, but then it became again negative. What we can see also on the MRI, we had this cranial nerves enhancement that we could see on the initial MRI, and then it disappeared. And the patients were also clinically improved. So that was, of course, we always show the best, but so it's something that we have seen. So that was, at least for this patient, probably helpful. So where do we stand? So to write manuscript, of course. We have also a nice program with translational analysis that will start soon. And then I think the nice point for discussion is what is the best intrathecal approach. And we discussed a bit with Egler also the LAX3, so that could be an option. So there are some discussion ongoing. And then I think that's always a challenge for patients with leptomeningeal metastases. We have several phase 1, 2. But to have randomized phase 3, that's always a challenge, but we should try to do these studies. That's to change your mind a bit, your brain. And now we move to the STRIKE study. So that's about immunotherapy or targeted therapy with SRS for patients with brain metastasis from melanoma or non-small cell lung cancer. So that's a phase 3 randomized study. You have shown the design already on the slide. So we have patients with melanoma. They should have newly diagnosed brain metastasis, and for patients with lung, they should have a new diagnosis of lung cancer plus brain metastasis at the time of the diagnosis because of pre-treatment, but that could be a bit confusing for the interpretation of the data. And patients are randomized 1:1 to arm A, SRS plus standard of care, systemic, versus systemic standard of care. And here, so this is quite, they receive the standard of care, brain MRI, and the extra CNS assessment as per standard practice. And we add on top quality of life and cognitive testing. So I think it would be interesting. And the primary objective is really to look at the central nervous system specific progression-free survival. So here we have discussed a bit. So yeah, patient. And I can show you, so early results. So the target is still, it's quite an ambitious trial. We need 190 patients. What we can see in Sweden were not too bad. So we have a total, we have, what is this? That's 9 patients. I think we have 11, yeah. But best site in Italy, so we have to do better. So we continue the effort. And you see for the moment it's 35 patients that have been enrolled and a bit more in the last month. So I think it's doing a bit better this trial now, the enrollment. So what was a bit the challenge, it was of course delay in activation of the sites. And so the trial was expanded to the Spanish sites, and it was good because they are enrolling patients. So that's was a good idea. But I think probably the most challenges is really the physician bias and also patient bias, because that's Everybody agrees that we do not have the answer to this question, but in fact, in a lot of sites, it's difficult to enroll a patient because physicians and patients do not want to be randomized because they know what is best. So that's, yeah, for me, the biggest challenge. And also what is a bit difficult, just like all the CNS meds related trials, that's to work together. And I think here we have managed to have a nice team and to work nicely together, and we can see the results. And just as the info, there will be an amendment that will be planned soon. And now, if you have questions, I will jump to the primary brain tumors.
Only one comment and question to the Department of Neuro-Oncology. I hope that the intrathecal treatment comes to a phase 3 trial. Then the question is, what would be the standard of care arm? Systemic treatment only, or craniospinal irradiation, maybe also with an approach that switch after progression? At least for some cases, we have very good data, and we see patients that benefit from craniospinal radiation.
Yeah, there are more data. Also, they are a bit limited in in melanoma. It's mainly for lung and breast. So I think we should try to get more data. I think it's nice to do it within a trial, of course. No, for me, I would love to compare and to this crossover. Why not? Because they will need more.
For LAC3?
Discussions are ongoing. So we'll see, but no, but I think we should plan something. Yeah. Patrick, I think you can join.
And we move on. Next speaker is Dr. Regina Reimann. She's a senior physician, Oberärztin, leitende Oberärztin here at the Institute of Neuropathology. Who's to blame for the title of the presentation? It's me. It was obviously driven by some discussions we had, I think, in the tumor board and afterwards. So, yeah, looking forward to your presentation.
Thank you for your introduction, Patrick. I just wanted to mention that it's not we neuropathologists who are confused by the classifier, but of course, the reports has to be as such that the communication to the clinician is not confused. And of course, most important, that the communication to the patients at the end should not be confused. Yes, I think we have heard it already. It was relatively fast. The complexity improved in neuropathology. And this is at the moment a bit the overview what we have as tools at the USZ. So we have both, of course, in parallel, second generation, so short read sequencing, and also third generation long read sequencing. The difference is that with short read sequencing, it's massive sequencing in parallel sequencing of short reads. And this has often goes with a higher accuracy. The other methods improve, but still, because we have this massive amplification, it goes to a higher accuracy of the reads. However, these methods come typically with longer running times and more difficulties in identification, also structural variants. And on the other hand, also we started with third generation sequencing, so long read sequencing. And this is for USZ at the moment that we started with the Minion nanopore. And this has the advantage that data can be collected in real time. And this has, therefore, this faster turnover time. And it's also, we can now detect structural variants. It comes with a bit higher levels of error. So at the moment that I wanted to say, we even discussing if we, besides the Minion, also will start with the Prometheus ion. as we have seen that it maybe comes with higher depths, reading depths. However, since we are in the same time when we are discussing about newer developments, of course, there are already new things coming. And I think this rapid changing environment makes it sometimes difficult and challenging to make the right strategic decisions. For example, now of course, it looks like there will be a fourth generation of sequencer with the sequencing by expansion. And of course, we have already heard the platform with the nanopore sequencing with, in some sense, even higher established settings with very fast turnover, so intraoperative tumor classification. And as it has been properly, of course, already in depth also discussed, of course, this fast turnaround time in new developments is a bit, is even too fast for the WH classification, and that's why we, of course, it's great to have this see impact now updates, that we have some guideline how to use these new techniques, how to use this new data on the entities. And I think this changes. We can also see over the time in our report. So this is a report from 2005 about the glioblastoma, at that time called glioblastoma multiforme. It is kind of 5 years before I started my training. And there you see that mostly the data was relying on the microscopical data and a bit on the immunohistochemical profile. 10 years later, we have to change now to glioblastoma. I would say the immunohistochemical information here was added, some molecularly immunohistochemical data. So IDH8, IDH1 was already stained, ATRX was already stained, and somehow integrated then here already into the diagnosis. And in this case also they excluded an oligodendroglioma by sequencing of the 1p19q. And then nowadays, as we have heard, we have now the integrated diagnosis. We also changed to the reports. We no longer have this descriptive format, but we rather have these structural approaches that we give from the histological setting the main points who are either important for classification or for prognostic types. We give, of course, molecular information. We give also define here if the molecular information is based on immunohistochemical data or if it's based on other things, or if it's on the EPIC chips, or if it's by next generation sequencing done. And then here, typically, we give then, of course, the final diagnosis based on the WHO classification, and then the grade and further relevant clinical information. So, focusing more on the epigenetic, all is based for the epigenetic classification. This is actually based only on the DNA methylation. Of course, there would be other epigenetic changes, but this diagnostic rely on the DNA methylation. So meaning that on the cytosine, a methyl group is added. And it was have seen that tumors have a certain pattern. And by this pattern, for example, you can better, this pattern is typical for a cell type. So even if metastases come from breast or colon, it has another methylation pattern. And also the clones stay the same, and typical some entity have the same pattern. This is because in the biology, some pathways are activating and also modifying the epigenetic of the tumors. Methylation, it was started in Heidelberg that they used this EPIC chip to do the array. And very central to do that is this bisulfite conversion. And that's where you change the non-methylated cytosine to uracil, and the methylated cytosine stay the cytosines. And you do one sample with bisulfite conversion and one without, and you compare. You hybridize them on that chip where you have certain points who are important methylation sites. You read it, so you sequence it and you analyze it. And the computation is done in such a way that you need a very rich library of other tumors who are annotated with a certain epigenetic profile. And then you look your sample where it fits best. So in all this island, you look to which, where it's nearest by. And this gives then a score how good the data of your tumor fit to these islands. And when these new entities come, this means that we have much more islands now on the card. This is the initial card map we had from David Kapur, published 2018. I said there is a second technology now with long-read sequencing, and with this we can now also do epigenetics. Long-read sequencing by nanopore, as indicated here, is based now that the whole DNA strand goes through a pore, and that it changes at every base a bit electric current, and that's why we can read it just in time. And now the great thing is that even modified base, so methylated base, can be read. So we no longer need the bisulfite conversion, and that's why we speed up the analysis so fast. Meaning that, as told, intraoperative, you can isolate the DNA, you can put it on that very little device here, goes into a pocket, and can on time classify the tumor. There are different classifiers. The most accessible, I would say, are the one for short-read sequencing, so it's the one epignostic from Heidelberg, and the Methylscape, so this is the US kind of NCI Bethesda classifier. For long-read, most are using the NanoDx, developed by Philipp Euskirchen, and there is a second one, the Sturgeon. In WestZ, we work based on the NanoDx. We know that the further challenges will be there, because one of them, because it will go to an IVDR, which comes with some workload, will be gently charged. And I think this will also change a bit how we will use this classifier. And the second challenge is, while these NanoDx and Sturgeons are freely available, so we can just as center download the scripts and implement it. However, you need access to the epigenetic data sets. And for many centers, like for us, it can be difficulty. So we work still with the copper, with the initial data sets to make our classification. And then you can imagine how many tumor groups came in the meantime into onto the map, and we cannot really classify them with NanoDx, which of course makes that we still have to decide where we go for, with NanoDx or with epignostic, because there we have more tumor entities. I would illustrate our work with three relatively simple cases. The first one is a 60-year-old man. It's a diffuse infiltrating glioma, and it has the typical morphology of oligodendroglioma. It came with necrosis and vascular glomeruli typical proliferations. So in that case, we thought, well, it looks like a classical oligodendroglioma of higher grade. We did our normal immunohistochemical panel. So we find really the IDH mutation. We find the RTX retained. The P53 is overexpressed in less than 1% of the tumor cells. So this is very well fitting to the histological morphology and is reassuring us that we're really dealing here with a normal oligodendroglioma. The key was a bit higher, combining nicely with the higher grade features we have seen. So in that case, because for the WHO classification now we need the 1p19q to add, we decided that we go with the simple nano-Dx approach because that we get much faster, and then we should have all the data available. And that's what we did. So we got the classification as oligodendroglioma, and with the copy number plot, we could also see the 1p19q. So the integrated diagnosis is oligodendroglioma of a ZNS grade 3. In our experience, typically histological unambiguous cases stay usually also molecularly unambiguous. The next case is a 39-year-old female. She also comes with a diffuse glioma. It has a mixed oligodendrogliomal astrocytoma-like morphology. In the past, we had the entity of an oligoastrocytoma, which is no longer in the WHO classification. We also have seen here focally a higher malignant grade with increased number of mitotic figures and higher cell densities. In that case, immunohistochemically, we not found an IDH mutation of R132. RTRix was retained, P53 was overexpressed. So it was a bit mixed from the immunohistochemical information, but with the P53, we were a bit more in favor now of astrocytoma. The key was in this higher proliferative area also increased. Interesting, on the nano-Dx, we had both the classification as an oligo and as an astrocytoma, but we had no 1p19q. So oligo was already at the nano-Dx level now excluded, and as we had a very nice match for IDH mutation, it was kind of confirmed that we go into the direction of IDH mutated glioma or astrocytoma in that case. Here is the map of the nano-Dx, and it's really at the border of oligo and astrocytoma. However, in the short read sequencing-based classification, we saw in both classifications an astrocytoma IDH mutation or both of lower grade. However, on the Oncomine, which we did because we could immunohistochemically not detect the typical IDH1 mutation, we found then another IDH mutation, proving it's an IDH mutated glioma, and we have seen the P53, which we already expected, and two further mutations who are in the literature described that they drive the astrocytoma towards a higher grade. And it fitted also with a higher tumor mutational burden. So we ended with the diagnosis of astrocytoma IDH mutants, but CNH-WH grade 3. So in some cases, we would say that the combination, so in a more equivocal cases, we see that really the combination of histomorphological molecular data really makes us to provide a diagnosis with more confidence. And the last case I want to present you is a 4-year-old boy. It's actually not a tumor patient, it's a patient with epileptic seizures. We saw a tissue cortex with dysmorphic neurons, also some balloon cells, and nicely shown also in the Vimentin staining. With some of the ganglion cells, we have the impression that they maybe are binuclear. BRAF was negative, Ki was low. CD4 was sometimes a bit bushy-like astrocyte. So we decided to go to exclude the ganglioma for a classifier. And we have seen that on the brain tumor classifier turned out to be the class normal brain tissue, and the Bethesda classifier was with a high score in favor of a glioneural tumor, so ganglioma. We ended in that case because also the CNV was very flat with the FCD type 2B according to the ILIA, was later also confirmed by the reference center by Blünke. But you see with that there can be mismatches between the classifier. For this case, it's maybe a bit more academic. However, we also see it with higher grades. For example, we often get that one classifier is saying that there is an inflammatory microenvironment, and the second classifier says it's a glioblastoma. We don't think it's a big problem because we always have all the data, all the molecular marker, and also have the histological data, and that's why we have to integrate it. And that's, of course, at the end our job to do in these cases. But since we also make all this information available and have it in all our reports, of course, it sometimes can be challenging how to communicate it in the best way that we really make sure that we understand. So what are the challenges? So I would say, yes, the rapid environment makes it to some extent really challenging to make the right decision about the techniques we implement. And of course, it will be also a bit challenging if one of the classifier changes a bit the availability. A challenge is for sure for the nanopore sequencing is that epigenetic library are not fully public available, and that some of the classifier have conflicting results, and in some extent also challenging, but they are in our view, we can sort that out, let's say. So that's the end of my presentation. I thank you for your attention.
Thank you very much, Regina, for nicely emphasizing the advantages, but also the challenges of this technology. Are there questions? You mentioned a couple of things in the end. Maybe you can briefly comment on the costs associated just with the technology.
What do you mean exactly? So with the prices we charge, or with the prices inside?
In the end, it's both, right?
Yes. You mean if the newer technology, how big the investment costs are? Yes. Really, it depends. I mean, with the Nano DX, the good thing was that the costs, for buying the devices are not high. But we have already seen that since it's much more used, the cost for the consumables goes up exactly. And of course, also if then classifier, if there is a fee, then costs also go up. And that's also, I think, why we discuss so much during our sessions what we do now next with the tumor sample. So we really think of what is now the best tool to do, or if we even should do it sometimes, because we don't want, of course, to just run molecular data if there is no need, and we just go add further costs, exactly.
Thank you.
Well, thank you very much for the very nice presentation. And I have no question. I just want to reconfirm that it's so important to combine the molecular results with the histology, because, of course, the classifiers can only identify cases that they have been trained with. For example, we, just for curiosity, we subjected normal pineal tissue to the methylation analysis, and it came out as a pineoloma or pineocytoma. Yeah? So because there was no normal pineal tissue profile before. Yeah? So one has to be very careful.
Thank you.
All right. No further questions. Thank you very much, Regina. Last but not least, we're moving on. Tibor Hotobachi, he is also Oberarzt Senior Physician here at the Institute of Neuropathology, and he, as you can see, will talk about the molecular workup of both primary as well as secondary brain tumors. Does it work with the microphone?
Should be. Yeah. Thank you, Patrick, for the introduction. Dear colleagues, so my talk is still revolving around the molecular workup of primary and secondary brain tumors. I am aiming to be complementary to two previous excellent talks by Guido and Regina. On an overview, I'm going to touch upon sort of the timely workflow of the diagnostic process, starting with the preoperative thing, which is mainly planning and logistics. The intraoperative, what we do when we receive the material and the specimen to assure a future optimal or ideal molecular diagnostics. Then regarding the genetics, the first stage of it is still possibly the immunohistochemistry and what are the options there. Then from day 2 on, we are planning in many of the cases the methylation, the copy number profile, characterization. So we request these studies, the classifiers, then when and how the sequencing, or for RNA changes, the fusion analysis shall be initiated. We will end up at the integrative diagnosis, as has been mentioned many times, and then the role of the tumor board. One aspect is the internal molecular tumor board, and then the neuro tumor board, which is also very important to reach the final diagnosis and the diagnostic decisions. And certainly all what we do are potentially involved in studies and research for the benefit of patients and the research community. So what happens the day before? This is a case of fortunately not every day and every case appearance when patient is enrolled or is to be enrolled in a study, and we receive an email the day before with the possibility of glioneuronal or glial tumor, but actually it is still open what the tumor can be. And what I'd like to emphasize that actually depending on the intraoperative diagnosis, so our first assessment, the case is going to be rooted either on the low grade, the high grade, or the sort of other type of tumor regarding preparation for study enrollment. And actually the decision, our decision, the first assessment is important because, for example, if it is a high grade glioma in the first assessment intraoperative, then fresh material is going to be sent off on the very day, and the whole process is going to be designed accordingly. In other cases, it is going to be different. Certainly, review of the clinical data is relevant from the molecular aspects also to see whether any genetic analysis has been performed, for example, in a tumor of a secondary lesion in the brain, which is also the topic of my talk. And then the second half, I'm going to touch upon that one as well. And at the day of the surgery, we receive the material, and then it comes to splitting up the sample. If it is voluminous and abundant, then usually it is not an issue, but sometimes it is really minute. Certainly depends on the localization of the tumor, the accessibility, the intraoperative events, also define how much we can get for diagnosis, and then we have to split it up for the different routes. Certainly diagnostics is the priority, and I already asked Guido what to do when the sample is small, and I agree with you. My and our approach is so that if we want to define the tumor according to WHO, we have to do some morphological assessment. There are some centers where in some cases it is not done like this. So, and then how to go back? Yeah. So when it comes to the intraoperative, we do the frozen section and possibly the smear. And back to the previous issue, when the sample is too small, then we are not doing the intraoperative smear because that part of the tissue is going to be destroyed. We are just doing the intraoperative section to make the diagnosis. And actually, the sample is very small. It is possible from the frozen section to do embedding for paraffin and formalin fixation. Certainly, if we receive an intraoperative section, even if our technicians, as they are very able and produce good quality work, it is unavoidable that the specimen, so this is the frozen one, has frozen artifacts, and it is not always easy to assess what it can be. This is a tumor with some glial features with a myxoid background, and also in line with the imaging finding, it was reported and turned out to be a myxoid astrocytoma. And sorry, I'm still learning how to go backwards. And this is the smear. I find the smear very useful for the intraoperative, maybe because I was trained in the UK, and in the UK we did only smears for only exceptional cases where frozen sections done, and especially for glial tumors, this can be very helpful. This is a smear result of a pilocytic astrocytoma. And actually here, so here in this our center, we do request the immunohistochemical stains that when we receive the frozen section, it means that next day we are going to get immunohistochemical results, and in view of the immunohistochemical results, the further molecular testing can be initiated or amended, or some of the requests may not be any more necessary. In the next stage, while the topic is on the molecular analysis, I'm going to focus on the immunohistochemistry, because immunohistochemistry is also capable of assessing some mutations or alterations, which is relatively cheap, has a good turnaround. So by next day, we are going to see the results, and diagnosis and initial diagnosis in most of the cases can be established within 24 hours. And then certainly there are the routine molecular analysis, which can also be done from formalin fixed material, but preferred from the frozen. Certainly the glial nature of a glioma can be established in a way. This is also a molecular analysis. It's very much 20th century. And what is certainly useful, the proliferative activity of the tumor, the cell cycle protein Ki67, which is a good guide. Then the genetic alterations which can be detected by immunohistochemistry. I give some examples. So histone 3 methylation, if it is lost, then it's a good sign of genetically defined midline glioma. This is the case when it is preserved, and when it were lost, then certainly the possibilities of the three different subtypes come into the picture, and one is the histone. Sorry, this is the case when it is lost. The previous one was when it is retained, and then we can go for the mutation-specific antibody, the histone 3K27M, which can actually define within 24 hours even the mutation of the case, which can be useful. Certainly the IDH mutation-specific antibody targeting the most frequent mutation is one of the most widely used immunohistochemical reactions, and is a good and quick way to specify the mutation status. The P53 can also be assessed by immunohistochemistry. If it is low like this, then it is rather wild type. My colleague Regina has shown a case with the mutation. ATRX, again, can be quite well and quite reliably defined also by immunohistochemistry. Another example is the INI1, which is in ATRT, is lost, like in this case, with the endogenous control of the endothelial cell. So this is again a mutated case defined by immunohistochemistry. As a final example is the histone 3 mutated hemispheric glioma, where again we have a good immunohistochemical marker to provide the genetic diagnosis quick and cheaply. So probably when these quick methods of intraoperative diagnosis, what Guido has mentioned, will become more widely available or affordable, then perhaps these mutation-specific antibodies will not have to be done so frequently, but at the moment they are useful. And let us not forget that in most parts of the world, genetic diagnosis is just simply not affordable because of the cost, but immunohistochemistry is accessible in most places. And finally, the BRAF mutation, like in gangliogliomas, and beta-catenin, which could be, this is a craniopharyngioma case, which is a wild type pattern with cell membrane and cytoplasmic positivity, and this is a mutated approach from a mutated example from adenomatous craniopharyngioma. So, and then when everything goes well, within 24 hours, with the immunohistochemistry, we can approach to a morphological phenotypic immunohistochemical diagnosis, and an example is that this is an astrocytic high-grade glioma with the IDH and ATRX wild type pattern suggestive of a GBM. And then when we have the classifier analysis, then in most of the cases, the diagnosis can be pinned down. With oligodendroglioma, because we need the 1p19q, following immunohistochemistry, just high-grade glioma, oligodendroglioma histotype can be done. If we do the nanopore, as Regina Raymond mentioned, we can get within a couple of days the 1p19q status and then provide the final diagnosis. And certainly there is scope for the further molecular analysis, which has been extensively discussed in the two previous talks. I am giving some examples on the problem cases, sort of when there is a mismatch. Fortunately, in 98% of the cases, the classifier brings us happiness and confirms the diagnosis done by the previous layers of morphology and immunohistochemistry. But this is an example, when one of the classifier gave us the results of an oligodendroglioma, the other classifier specified as a high-grade astrocytoma. Fortunately, this was not that much a difficult case, because even the immunohistochemistry and then the copy number profile was clear that this was an oligodendroglioma. But still, it's just an example that we have to be careful with the classifiers, and we have to stay vigilant and make sure that we make the good diagnosis. And other issue is when the classifier score is very low. And it happens time to time. And when the tumor cell content is low, then it can explain the low classifier score. And with balance of that, we can make a diagnosis. But as Guido said, when we have low tumor content, like in an infiltrative zone, then we prefer the sequencing analysis for mutations, because it can be anticipated that the methylation is not going to be conclusive. Certainly the methylation profile, the MGMT promoter methylation is an important information what we can and do get routinely from the classifier as an additional value for gliomas. And as next, the DNA-based analysis, we apply frequently the OCA DNA panel with a list of genes which are covering the relevant, most of the relevant genes for brain tumors, primary brain tumors. And in cases where fusion, for example, BRAF fusion comes into question, then the RNA part is going to be applied, like in this case, which turned out to be a pilocytic astrocytoma with BRAF fusion. I can skip this file because Regina has already mentioned the usefulness of nanopore classifiers, and certainly there are other options. Sometimes we refer the cases to other centers, sometimes for consultation, but usually it is part of the study protocol. We can do consultations. In these days, telepathology makes it much easier than in the old days sending slides around. And certainly there are many other possible applications what we can do with the tissue for research purposes. 3D neuropathology is something for the future, hopefully for the near future. In our department, Anna Maria Royce, Daniel Kirschenbaum, also Regina Raymond, and myself have been to variable extent involved in 3D neuropathology developments. And this is it would be great to have 3D. Perhaps I'm going to see that in routine in my life. And then the integrated diagnosis is important. Certainly, I want to mention that there are more and more cases coming up with not elsewhere classified. We have learned from Guido's talk that with the growing number of the different methylation subtypes, it is methylation types, it is growing to be more, and then the next WHO book is going to help us for some times to get lower amount of NECs. With metastatic tumors, we have the good opportunity because we are not the same institute, but we are in the same building with the general pathologist, and there is a very good collegial relationship, so we can consult if when we wish. Often the molecular characterization like lung, melanoma, and breast is a routine reflex procedure. Methylation classifiers can also help with secondary tumors, metastatic tumors, also with carcinomas. For sarcomas, there are special panels here in the institute what we can apply. All the hematological cases will again be consulted with a specialist hematopathologist, and the cases are going to be referred to the specialist tumor board from the neurotumor board after discussion. Finally, just an example, when tumor with sarcomatous growth has been diagnosed also intraoperatively, and after the molecular workup, it showed cytokeratin positivity, but it was highly inconsistent where the primary tumor could come from, and the Bethesda classifier with a high score identified lung adenocarcinoma. The sarcoma classifier one was not helpful, and then the UMA plot, which is another aspect what is important for our decision making, put this tumor nicely in the group of lung adenocarcinomas, and the mutation analysis provided KRAS and TP53 mutation, and finally with imaging a primary tumor suspect lesion was found also in the lung. I have already said that the clinical and research studies are of importance, and we are contributing to them as much as possible, and we can. And actually, all or most it has already been said. The diagnosis is multi-layered. Tissue is important for diagnosis and research. The neck, not elsewhere classified, problematic, and the splitting and lumping. So we are now in the process of splitting with these many new entities, and I'm very happy to hear that there is a working group for lumping. Yeah, so to define what a new WHO entity is, because hundreds of entities is not good for us diagnosticians, and probably also not good for from the therapeutic or clinical treatment point of view. Thank you for your attention.
Thank you very much, Tibor, for guiding us through all these molecular options. Let's see if there is still some energy in the room and to ask you some questions. Yes, there's the first one.
Okay, thank you, Tibor, for the presentation. What is your view? When should we use this methylation profiling, or is it feasible now for metastasis of unknown primary?
Pardon?
Methylation classifier for metastasis of unknown primary. When you look, yes.
Yes. So as I mentioned, it can be useful. So especially the Bethesda in our experience are pretty good at identifying some of the primary brain tumors, for example, even for breast cancer. But in this case, identified the lung cancer with a high score.
Do you
Was
use
it that question?
Do you use it often, or?
More and more often. Yeah.
And what kind of primary tumor do you have?
So we are not doing that often because, you know, this methylation process, so it's a bit expensive and often not necessary. For such cases, first I discuss it with the respective general pathologists, and usually they have, for example, the Lungen algorithmus, so the lung panel, and we go in that direction. But it's possible. Yeah.
Any further question? If this is not the case, thank you very much. We are a couple of minutes late, so I'd like to thank all the speakers for their contributions, the sponsors for supporting us. you for staying so long, attending, and there is an apéro next door in the Dick and Davy, right? And everybody's invited. All right, have a nice evening.